So what I'm going to share with you today, I call assessment technology in the chiropractic office. I know that words mean things, so I'm not going to use diagnosis, I'm not going to use treat, I'm not going to use all of those medical terms. In chiropractic, we call the assessment. And that's where we take all of the information that we've gathered to, first of all, determine if there is subluxation in the system, determine where it's at, determine how specific it is, and then decide, because we're doctors, what we're going to do about it. And that's not called a treatment. It's called delivering and adjusting thrust, because if you look at the philosophy, we don't adjust, the body does, the knee does. It takes an external concussive force, converts it to an internal constructive force.
Say that again.
Innate takes an external concussive or destructive force and converts it to an internal constructive building force. That's the job of innate. We'll go over that in just a second when we walk through the philosophies. So my words are intentional, and they're intentionally not medical, and they intentionally are as close as I can be with my only 30 years of doing this, getting into the depth of the philosophy. So bear with me, and hopefully we'll all learn something through this, because this, again, it's my thoughts. I will say some of the stuff I've made a judgment call on based upon my exposure to what we're talking about. So I could be completely wrong. Somebody with more exposure in that area can correct me, and I'm happy to do that. But the point of this is not to give you absolute answers to some of my questions. The point of this is to get you to question, why am I using this assessment technology? Why am I using this assessment tool? And where does it fit in what I say I do? Does that make sense? Is that worth your hour this morning?
Yeah, yes.
Okay, so if I can get you thinking, okay, because you can use that same rubric to attack or look at any new thing that comes to your door 20 years from now, 50 years from now. Does it fit with our philosophy? And I think this rubric helps us, okay? All right, so what are we assessing? So basically the assessment is, what's the status of innate in our body? Or not in our body, but in our client's body, our practice member's body. What's the status of innate? Is it fully adapting? Is it being interfered with? Is it in an adaptive state where it's going from being interfered with to being free from interference? How is innate functioning? That's the sole purpose, according to our philosophy, on what we do, of detecting this interference. Now, as chiropractors, the only thing we can help innate with is delivering that adjusting thrust. So we determine, is there a presence or is there an absence? Both of those are positive. You know, we can check, is there interference? And then we can also check, are they clear? And both of those are valid findings. It's not one and, you know what I'm saying? It's like, if they're not clear, then they must be interfered with. If they're not interfered with, they must be clear. You have checks for both. Does that make sense? Yeah, I know it's 7 o'clock in the morning, so.
Yes, sir.
Thank you very much. I was going to go into that. One of my backgrounds, I'm a 3rd-degree black belt in Taekwondo. And so when I speak and teach, I'm used to getting the answers back. It's been a little while since I taught, but that feedback is good. And usually when I was teaching, especially my advanced students, if after 5 minutes I wasn't getting a response, we do calisthenics, or they would do calisthenics. Obviously, I don't do much of that anymore. So what is this chiropractic vertebral subluxation that we're talking about? Basically, it's a malposition, malfunction of spinal motor units, which are two vertebrae next to each other. They cause an occlusion in the frame that the nerves occupy, putting pressure on that spinal nerve, which ultimately interferes with the transfer of mental impulse. Now, mental impulse is not just the nerve firing, it's the information carried by the nerve. Because we all know we can take that nerve out of a frog leg and zap it with some AAA battery juice, right? And it'll fire that muscle it's attached to, right? We've done that. That's not mental impulse. That's electrical impulse. It's not the same, because innate, through the mental impulse, sends coordinated signals to produce a specific self-preserving action. Does that make sense?
Say that again. Coordinated.
Oh gosh.
You're so good at words.
I know, I told you that, didn't I?
All right, I should record
So
it.
innate's job, well, I am too, so I can remember how good I am. I amaze myself most times. Innate's job is to send coordinated information down these nerves called mental impulse. And so its job is to send self-preserving information to the target cell. And by definition, all of innate's mental impulses are coordinated for the preservation of self. Make sense?
Just remember from national, so
Well,
we don't
yes.
teach us.
Sorry. But Sigafoos came out of national, so not all hope is lost. Well, that's what, 1 in a billion? 6
Two,
special.
hopefully.
Okay, well, you're here, so that's a help, so we appreciate that. So that's what we're looking for, that's what we're assessing, that's everything we do in our office should be towards that end. Is it there? Where is it? What is it? And what am I gonna do about it? Regardless of your technique, regardless of any of the other things you do, everything should be in the assessment phase, in the information gathering phase, is those questions. Is it there? What is it? Where is it? What is it? And what am I going to do about it? Okay, purpose of innate. So we're going to get into some of the Green Book stuff here. Just Stevenson's. We're not diving deep into some of the later books. This is just from Stevenson's textbook. This is from Stevenson's textbook. So when he goes through the freshman text, in fact, it's not even into the freshman text. This is freshman orientation text. This is the introduction to the book. So this is like, I'm not even starting school yet. Here's stuff you need to know. Okay? So principle 21, the mission of innate is to maintain the material of the body of a living thing, us, an active organization. I already covered that in my own words. 23 says the function of innate is to adapt universal forces, which are destructive in nature, and universal matter to be used in the body. And again, since it's a job for Principle 21 is to have an active organization, we have to assume that it takes these external destructive forces and converts it to internal constructive, good, useful forces and matter. And here it is, we'll have coordinated action for mutual benefit. And this mutual benefit is not me and Paul, but all of the target cells, all of the cells in our body. It will do that in a coordinated way, not just so the liver prospers, but the liver and the kidney and the intestines, so everything prospers within this unit called our body. Limits of adaptation. Bless you. Did I stop it? Did you cover it?
I forgot my mask,
Okay.
so he stopped it.
Okay. Usually if you say bless you before the sneeze happens, it sometimes stops it. But
I
Anyway.
accepted that.
innate intelligence adapts forces and matter for the body as long as it can do so without breaking a universal law. So if you jump up and down, gravity stopping when you hit the floor, the body will adapt that or deal with it, dissipate it, so it doesn't damage the body. If you go out here and jump off the building, universal law says that speed and the force absorbed has to go someplace, and the body only has a limited ability to adapt to that. Does that make sense? And so we call this a limitation of matter. Is there's only so much your body can take, and if the external destructive forces and matter act upon you in such a way that it overwhelms your ability to adapt, you die. So you adapt, you die. One of the two, or you're in extreme physical distress, whatever. All right, so character of innate, again, I've covered this a lot just in talking about it, but the innate intelligence, it has some limits. The other limit, first of all, it's limitation of matter. The other one is it cannot injure or destroy the structures in which it works. So innate intelligence, by definition, cannot do anything to cause the body or the tissue cells a negative result. There's a lot you can infer and imply from that, but that's the definitions we work with. We cool with that? Universal is destructive, innate or constructive. I've said that many times. Here it is in principle form. And normally, innate in its normal state, well, innate is always normal. Innate intelligence is always normal. We go back to the triune, which is one of the early principles. We have intelligence creates force, which moves matter. Those are the three things that we have to deal with philosophy for chiropractic. That's actually universal philosophy. Innate's always at 100%. Intelligence is always at 100%, whether it's universal or innate. It's always at 100%. There's always enough telling you exactly what to do, when to do, how to do. That always creates the exact amount of force it needs, 100%. Whether you're an amoeba or an elephant, doesn't matter. It's always 100% to move the matter that may have problems with it. Do you understand? So innate intelligence is always normal. We can't assume that if my hand is not working that it's a problem of intelligence. Go back to the previous one. The problem is is limitations of matter, which comes up to the next one, which is probably interference in the transmission of those innate forces, also known as mental impulse. The mental impulse is 100%, but it's not being carried all the way to its target. So there's something causing interference with the transmittal of that information. And dis-ease, I want to let you know, is not purely a chiropractic term. I actually have a medical doctor. I took a class last fall on the opioid epidemic, and this medical doctor, actually a professor at Harvard Medical School, with multiple PhDs on stuff, in his talk, just threw out dis-ease will cause your patients to want more and more opioids. I'm like, whoa. And he actually said the hyphen in it. So this is not a concept that you have to be afraid of or embarrassed about or wonder. People understand when you say this is a dis-ease. This is a unease. This is a not ease situation. It's a disharmony. It's an unbalance. Okay? It doesn't mean disease as in a disease process or pathology. That's just an aside. That didn't cost you anything extra. Okay? Cool. Subluxation. Now, just to let you know, Sherman has all these principles on their walls in the new decoration, and people could go in and buy one of the principles. And I happened to be there when they opened up bidding, and I bought this one. So I own the term subluxation. So anytime you need to get a jar in your office, anytime that word's used or anything, just print it out. You need to put money in it and send it to me, and then I'll take a good portion, some of it, and give it to Sherman. Okay, just to let you know, I own this. I have pictures if you need to see it.
Some of it.
Well, you know, administrative costs.
90-10.
Yeah. The principle of coordination. Coordination is a principle of harmonious ease in all parts of the organism, not just the liver's functioning well, but the kidneys aren't. In fulfilling their offices and purposes, fulfilling what they were built for, what they were designed for. All right, so again, to sum up all of those, the purpose of innate intelligence is to adapt universal forces in matter to be used for innate work.
Can I ask you something? Because when you were in principle number 24, you say that 24. You say like if we adapt, we die.
No, we adapt or we die.
Oh, or.
Yeah, or it's a big difference.
I guess so.
Yeah. That's a big difference.
Yeah.
So did that mess up everything else? Do I have to start there again and go
yes,
forward?
but now I get it.
Okay.
Yeah. Okay.
Because I'm happy to start over.
No.
Okay.
I'm good. Thank you.
No, that. Thanks for calling it out, because that would mess you up the rest of the day. Or probably for the rest of the
It
month.
was working hard.
No, either you adapt or you die.
Yeah.
I mean,
Now we can
all,
have this.
yeah, all kinds of companies use that, adapt or die. The Marines use that, right? Adapt or die. I mean, it's a fundamental understanding of how things work. All right, so we've got the groundwork laid for what we're looking for, right? Innate intelligence is always going to be normal, so we're not looking for a bad innate intelligence. There's no such thing. Okay? We're not looking for bad mental impulses being created, because that's not, by definition, possible. We're looking for where there's interference in the transfer of those mental impulses, and that's what our assessment technology does. But let's examine what the physical manifestation of that interference is, and we call it vertebral subluxation. And again, we have Principle 31. We have the definition and expansion of that. This is Stevenson's classic definition of vertebral subluxation, the chiropractic subluxation. And you guys know this by heart, right? 4 parts, MOPI. Anybody want to give me, except for Paul? He was there when it was written, so.
Misalignment of pressure,
So misalignment of juxtaposed segments
yeah.
causing
Oppression of the nerves.
oppression. I like oppression, but it's occlusion of the foramen. Oppression of the nerve, that's really good. I like that. I really do.
I remember the
Well,
P.
pressure, so occlusion, pressure,
Vision.
interference.
Interference.
Nailed it.
Interference. Did I get it?
Good
Yay! But it's not just interference in nerve function, it's interference in the transfer of mental impulse. Okay? We have to be really clear about that. And that gets into second, third, fourth level thinking about what we do, because mental impulse is only from the brain out, so it's only afferent, it's not, or efferent, it's not afferent, it's not sensory. It may have some implications for that, but technically the subluxation is only sending out. If you look at the definition, and we can argue about that all day long, just go by what the definition says. Mental force is that something that is je ne sais quoi, transmitted by nerves, which unites intelligence with matter. So we're talking about that mental force, that mental impulse. It's that information carried along the nerve impulse. So it's the information carried on that. So if we think about telephones, anybody remember wired telephones? Okay, it works with wireless too, but the carrier is the electricity. But the sound waves encoded in that and carried along that. So if we have an electrical impulse from whatever that goes into our phone system, we call that static. It works in a stereo system, whatever. If we're not quite in tune with the radio station, we get static, right? But when we're perfectly in tune, we don't get static, we only get the message sent along that carrier wave. Does it make sense? So the nerve impulse is the carrier wave. The mental impulse is the information carried by the nerve impulse. All right, adaptation versus pattern. Adaptation is dynamic, it's constantly changing, moment by moment by moment by moment. Our body, our innate intelligence is analyzing the situation, our brain's analyzing it, and intelligence is dealing with it and coming up with a way to dynamically deal with whatever's being thrown at it. If you're in pattern, that means you have the same response no matter what's thrown at you. If you throw a baseball at me and I do this and catch it in my glove, that's normal, right? But if you throw a spear at me and I do this, it's probably not normal. If you throw a snowball at me on this side and I go like this, it's not normal. I'm stuck in a reactive pattern. Does it make sense? Getting that? So that's one of the differences between adaptation and pattern. Adaptation is responsive. It's going to respond to things, where a pattern just tends to fire no matter what. So even if we're talking, my hand will go, catch the ball, catch the ball, catch the ball, catch the ball, catch the ball. Lunch, catch the ball. Dinner, catch the ball. Sleep, catch the ball. You see what I'm saying? It's just firing all the time. It's not really responsive to the stimulus coming in. Adaptation is always, always, always in proportion. If adaptation is keeping my balance, you come and push me, I'm going to resist in a normal way where I'm going to continue to keep my balance. Where a pattern is, you push me once and I take a couple steps back and I take a few steps forward. You push me real hard, I might take 5 steps back, but I'm only going to take 2 steps forward because the response is the same. You might come and not touch me, but I might take 2 steps forward. The response is the same, so it's not proportional to whatever the attack is.
You call it non-responsive. Can you clarify that in terms of physical, chemical, emotional stresses? Non-responsive to the concussive forces that apply to the body.
Right, so a mental state of being constantly agitated or nervous without any reason that they can come up with internally or externally why. Constantly being out of balance chemically in the body, like type 1 diabetes, hyperlipidemia, any of those things where there's no, I mean, their diet's right, everything's right, but their body's still not chemically balanced. Does that make sense? So it's not responsive to the food they're eating, it's not responsive to the exercise they're doing, it's just stuck, you know, that I'm only gonna ever produce 10 units of insulin in the cell no matter what, because no matter what the brain tells that cell to produce, it's being interfered with, and so it's not responsive to the mental impulse. So it can be a-responsive, hyper-responsive, hypo-responsive, occasionally you might hit it on the nose, but it's not really in proportion to the stimulus. And it may just fire anyway, just out of the blue, because we know that if there's pressure on the nerve, it can just fire with no brain stimulus, the pressure itself. So that's what I mean by non-responsive to the situation, non-responsive to the brain. Does that help? And again, these are my thoughts.
Sure.
And that those words that I'm using that I understand you may not quite have the same definition as I do, and that's fine. That's why I love these conversations, especially with somebody like Paul who teaches young ones how to think too. So, any other questions about that before I go on?
Doc, sometimes I've had patients come in and they show a pattern of already being straight down the line, blue line, all green. I know I may be jumping ahead a little bit.
Well, let me stop you there.
Yeah,
Again, thank you for volunteering this as an example. 2 things. Patient, you're already in I'm the doctor, I'm going to heal you mode.
Right.
Second, pattern is not just thermography.
Okay.
Pattern is not just x-ray. Pattern is not just leg checks. Pattern is not just any of that other stuff.
Okay.
Pattern is all of your assessments showing a pattern
Okay.
over time,
Okay.
so that when I see this in one of the things I do, I know what the rest are probably going to be. That's when you went to say that I know this person's pattern.
Right.
I have a client. She's in her late 60s, early 70s. Her normal is off the chart bottom left to off the chart top right. And it makes this beautiful, smooth curve.
Translucent.
Okay? When she comes in, if it's less than that, she's actually out of balance and subluxated because all my other assessments say so.
Okay.
So don't use that.
Okay.
The only time that they should be perfectly straight on that center blue line is if they're dead.
Oh, wow.
Because of, okay, they should be constantly moving. Now, they shouldn't be constantly moving 2 or 3 degrees like that, but you're constantly going to see some things. So you have to be careful about what we taking one test and saying, oh, you're always in pattern. Just buy this one test only ever.
Right.
Now, if that's what shows up and it agrees with everything else you've done, which we're going to go through here, then you can say this indicates that they probably are in pattern. You see the subtle differences?
Yeah. I see.
Unfortunately, this is not about anybody in this room or anybody you know in the profession, okay? So
Right.
don't be telling stories on me. But sometimes we as people get lazy. And we hear something, it's like, oh, that's got to be the gospel truth because that person said it, who I don't know or trust anyway, but they said it, so it's got to be true. So we have to be careful and step back and look and make sure, because we are doctors. We have people's lives literally in our hands unless you do an instrument technique, right? So don't be, thank you for volunteering. I know you don't do that at your office. Thank you for volunteering that so I can cover that.
Yeah.
Can I ask him a question or ask a
Sure, go
question?
ahead.
Are you talking about the lines or are you talking about the graphs?
Well, yeah, in upper cervical, DHS, we were trained that we find the pattern right, then we start adjusting, and then as it moves to all green, you're clear.
Sure.
And so my thought process, well, if somebody comes in, they're already all green, is the thermography saying that they're already clear?
Could be. That's the other thing is, just because a person shows up at your office doesn't mean you adjust them. Because if they are clear and you adjust them, it's not an adjustment, it's a manipulation, it's assault and battery.
Right.
Because they don't need
What's
it.
tricky is
Yeah.
they may already have neck pain, and when you're palpating, you may feel, tone or the subluxation, but on the thermography, they're showing up all green. You're like, well,
Well, but see that, but that's why we're doctors.
right.
We don't just say,
Exam to do it.
it's not a check box like, okay, you pass, you fail. It's, something's not quite right here. Let me step back and think about this a little bit. Okay, so the thermography says they're balanced, but they have pain and tenderness. Is the pain and tenderness by itself an indicator there's subluxation? No.
Yeah.
It's a symptom. Now, there's a puffy capsule. There's restriction of motion, but there's no interference because thermography says it's balanced. Let me do some other interference checks.
All right.
No interference, pain, tenderness, swelling. Okay, so what do we have here? Do we have a subluxation? By definition, no, because there's no interference. And one of the hardest things to do as a doctor is like, listen, I know you want to punch me in the face by telling you this because I know you're in a lot of pain, but if you're in balance, there's nothing I can do for you.
All right.
You know, go home, come back tomorrow, let's check you again. Because really what we're doing is when do we not insult the system
Right.
by putting in what we intend as a adjusting thrust, which is always concussive because it's universal outside. It's always destructive. If they don't need that, it becomes 100% destructive for that patient, for that client, for that person on the table, right? Because there's nothing for them to correct. So what do they do with that outside destructive force? It becomes a destructive force inside. See, so
It's very difficult when you're
Yeah.
you're trained to adjust. So
Yeah,
it's hard to
exactly.
say,
So-
today we don't adjust.
in Titronics, what we say is we show you when not to adjust. We give you indicators when not to adjust because if vertebral subluxation is as bad as we say it is, and it is, plus a whole lot more than we realize, why would we want to introduce a force that may cause one?
Understand?
That's what I have to go through with my clients too. It's like, listen, if you're clear, you're clear. Nothing I can do, but I don't care if you're bleeding out, whatever. I'll do first aid, but that's not chiropractic.
Yeah.
Doesn't mean it doesn't mean you need adjustment. The only time you need adjustment is if you're stuck, not adapting, in interference at a vertebral level. It's not moving appropriately.
Not gonna give them a feeling if they don't have a cavity.
I'll give them a hug, yeah, exactly. And I'm not going to change the oil just because their car's knocking at me. So we have to draw a line someplace. And again, like I said at the beginning, I work from definitions. I work from these constructs. And just like any speaker, we really narrow it down so we can get the point across in the talk. But this is something I don't vary from. Okay. And I'm sorry to point you out, and I know
No,
you had
that's-
others to things to say after that, but
Not learning if we don't.
good.
Challenge it.
So how does this all work? Let's get down into some physical science. Basically, the autonomic nervous system has got two branches, right? The sympathetic, fight, flight, the parasympathetic, rest, digest, right? The sympathetic is that tense, hyperreactive, non-responsive. I'm going to do this anyway. I'm going through that wall. I don't care if it's a paper thin or if it's 5 foot thick. I'm going through the wall. It doesn't matter because I've got so much stress in my body, whether it's good stress, bad stress, whatever. It's there. And what are we looking for in the autonomics? Starts with a B, ends with Allen's. Balance. Thank you. Yes.
I was like, into the what?
Okay. So the bottom statements here, when I found this graphic, really, really sum it up. If you have a sympathetic dominant system, you're geared and chemically driven for short-term survival. When you have a balanced system where a parasympathetic has presence, you're geared for long-term survival. Okay? So long-term survival, that's days full of life and life full of days. That's a really good place to be. Got it? All right, so assessment technology. So we're going to go through some things. I'm just going to throw them out here. Well, no, you know what? I'm not going to throw them out. You're going to throw them out here. What are some tools that a chiropractor might use, you or somebody you know or somebody you've heard about? What are some assessment tools? These are the techniques, the procedures, policies, tools, technology,
Everything.
mechanism things. What is it that gives us, as the doctor, as the chiropractor, the information to determine, is there, where is it, what is it, those three things. So just throw some out here. What are some things?
Well,
X-ray.
X-ray. That's always the first one. That was the first technology in chiropractic, 1915.
Outpatient.
Palpation, very good. That was even before X-ray.
Like
So-
that.
You do it one at a time. Leg checks, good. So that's a technique assessment, right? Whether you're using Pierce or Thompson or any of the leg checks. What else?
Heart rate variability.
Heart rate variability is a check people use.
Nervous go.
Nervous scope,
Titro.
Titron thermography, yeah, paraspinal thermography.
Substation.
Substation, paraspinal thermography. SEMG, HRV, no, those are all valid. Those are all valid tests and assessments. Balance, arm checks. People in the back, you got anything to contribute? I'm already overwhelming you with my awesomeness. I understand.
How about motion? Do you consider like?
Motion palpation, or
Yeah, but like.
okay, range of motion. Good.
Challenges.
Challenges. So the
Challenge.
challenges. Okay, so part of the assessment.
Postural analysis.
Postural analysis. Good. All of that and probably more, right? You can open a dynamic chiropractic magazine and see something new. You can open up the Script Pesco catalog and see something new, right? So let's just break it down. So we have range of motion. We have stuff to do with motion. So we have analog, digital. We have motion palpation. We have thermography. We have handheld. We have the cameras. We have electric, SEMG, HRV, those kinds of things. We have imaging, radiographic, static, X-ray, motion X-ray. We have MRI, static, motion. We have CT, static and motion. We have CBCT. We have ultrasound, all of those things, right? And then we have technique assessments. So Thompson Activator, go down the list of all of those things. They have techniques within them and probably a system of techniques to help you identify, is there one, where is it, and what is it, right? And that's a cascade of what we do. And then you also have postural. So you have the spinal analysis machine, which is a bunch of strings on tubes. Then you also have postural, which is a way of analyzing the posture with your phone or tablet. And again, this is just a very limited one just for the sake of pointing out some categories. Okay? Do you think that's a pretty good covering of what's out there and available? Did I miss anything that's obvious? So I am the sales and marketing director and part of the leadership team for Titronics. But this is not a Titronics-centric presentation. The next one, we get into thermography and that stuff, and that's going to be different. But even that's not Titronics-centric. It's more the math, physiology, and all that stuff of thermography in the first place. All right, so where do these fit in? Again, if what we're looking for is this thing called the chiropractic subluxation, and it's defined as MOP and I, where do these assessment technologies fit in? And what is the resolution it provides? Does it show that there is a subluxation somewhere? Does it show that it's in the cervical spine, but we don't know which one? Does it show it's in C2, but we don't know which way? Or does it actually give us a listing? So that's when I say resolution, it's not in solving, but it's like the resolution of your TV. How fine can we see? Is it an old 12-inch black and white CRT that has, like 120p? Or is it a 4K ultra high definition resolution? Does that make sense? That's what I mean by resolution. And is it specific and is it scientific? Right? Because if it's not, excuse me, if chiropractic is anything, it's specific, right? By definition, what's the saying?
Chiropractic specific or it's not.
There you go. Right? It's one of the things that's they're called epigrams, right? So is it specific? And what do we say? What do we say from stage here? Deliver the specific scientific chiropractic adjustment, right? So let's use that as part of it because those are both essential as well. So this is the rubric I came up with. So we have adapt. Does it show adaptation? Does it show pattern? Which part of MOP and I does it show? How specific is it? And is there scientific validation behind it? Make sense?
What does MLPI mean again?
Malposition.
Oh, okay.
Occlusion, pressure.
Yeah, malposition, malfunction. two joints, the two spinal segments not behaving well with their neighbor, causing occlusion of the foramen, putting pressure on the spinal nerve, causing interference.
I'm struggling to remember all the words too.
Well, and the next one, we're actually going to that a little bit more because, you know, if anything, our profession has had a huge discussion on the definition and the validity, and if it exists to begin with. And Dr. Kent did a great paper in 1997, 99, showing all of the prevalent chiropractic theories or philosophical theories on subluxation and how they all resolve back to MLPI. So regardless of which one you tune to, they come back to these 4 categories anyway. So that's what I use in my rubric, because I could use a 5-part or the 27-part, but that just makes things messy. I'm just gonna go back to these 4 parts, okay? It's my presentation, you don't like it? Read something. Are we okay with this rubric? Again, this is just something that came out of my brain and how I'm gonna look at things. This has already changed in the last 6 months because of the way I'm thinking about things. If you see something you want to add and change and use, please do. But what I'm challenging you with this class is let's think about what we use and how it can or can't help us and what we say we do. Make sense? We cool with this? Any questions about this? All right, so let's take a look at the first one. We need a check mark if it does it okay. And pressure is one of those things. It's part of the definitions. I don't know of any technology that can actually measure the pressure on the nerve without causing pressure on the nerve. And so we have to do a little bit of assuming at this point in our technological advancement that if there's M&O and there's I, there's probably, we can assume there's pressure. If you just have I, you can't assume that there's pressure. Because that interference can come from anywhere. It can come from intervertebral foramen. It could be a spinal lesion. It could be a brain tumor, or it can be something in the elbow. There's something else that can cause the interference. Does that make sense? So we can't assume pressure if all we get from that assessment technology is interference. We okay with that?
Yep.
Oh, all right.
Sir, yes, sir.
Thank you. So motion. You know, there's different ways of analyzing motion. You know, we can watch somebody walk down the hallway and say, okay, your right SI is not nutating or nucating, whatever it is. It's not moving like it's supposed to. So we can make that visual assessment. That goes into our assessment checklist. Palpation, we can actually, you know, stand there, do the march. Let's see how the things are moving. Is it moving in a balanced way? You know, technique, we can do some motion analysis. We can do the analog motion analysis. It's called that little plastic thing. What's it called? A goniometer. We can do analog because, you know, that's not a digital. But we can do all kinds of different techniques and then we can also get into the current age with highly specific, repeatable, precise electronic measurements of motion, either as a kinematic chain or specific joints. Motion palpation. I put it here, but I also know it's part of a technique, so don't get too wrapped up on where I put this because I know it's more than just this. But motion palpation is analyzing the motion of the segments based upon that highly specific train. Okay? Range of motion technology. You've got the wired ones, you've got the wireless ones, you've got the ones we sell, and the ones that everybody else sells. You've got, you know, all kinds of them out there because chiropractic is not the only profession out there that deals with range of motion. So there's a huge market in the orthopedics, huge market in the physical therapy, huge market in orthopedic therapy, occupational therapy. They have produced devices to be really good at this. And then orthopedic tests. So it is a range of motion with some other things attached to it, but it is saying how far can you move this joint before something happens. And then technique. These, again, I'm not saying that these are only part of range of motion. I'm saying range of motion is part of that technique assessment. Make sense? Because there's a lot more going on here in this picture than just range of motion. But the motion of the joint is part of that assessment. And this is just an Activator methods, again, this is, again, more than just range of motion, but we are looking for range of motion during this assessment. Putting a challenge, actually putting the adjusting force in with the level 5. Again, not necessarily testing the range of motion of the shoulders, but using range of motion to help us with the assessment. Thompson, leg checks, same thing, okay? So how are we going to put these in here? Technique, does it show us adaptation or pattern? It shows us whether the person's adapting or not. When you look at the leg checks, doing the technique analysis, it shows us whether they're adapting, the challenges and all that stuff. It shows us adaptation. It does show us pattern. That's the whole purpose of a techniques assessment. It's like you always got to write pelvic deficiency. I know exactly based upon you. You know, if you came in with the right pelvic deficiency and you came in, doesn't mean you have the same subluxation, but your pattern shows that way, which means that, and his shows that, which means that. So pattern is also very specific to the person, not to the findings. But that's the whole point of the technique assessments, right? Is to give me they're in pattern. I can see by what I'm doing if there's pattern. Techniques do show some motion interference. They do not show occlusion, right? You can assume occlusion, but doesn't show it directly, and then it does show interference. You're not responding to the challenges, not responding to the techniques of assessing during a technique assessment. Its whole purpose is to show is the body responding in a balanced, appropriate way. Make sense? And this is really cool because the techniques came out of chiropractic, so I was hoping that I'd come to those results when I assessed it. We cool with that? So is it on range of motion? It shows us motion malposition, right? Does it show us occlusion? Does it show us interference? No, not really. Motion palpation, just motion palpation
So
itself.
when you said range of motion with like orthopedic tests, there are orthopedic tests that you test for occlusion of certain
At the
organs
intervertebral foramen or anywhere in the chain?
in the chain.
Yeah, see, that's what, remember, occlusion at the intervertebral foramen. So if it's a spinal lesion internal, that's not part of the chiropractic definition of subluxation. So occlusion here in this definition is only at the IVF from the misalignment malposition. What?
I just want to say hi, good morning.
Hi, Jorge, how are you? Love you, man.
And I did my own research, and about 70% of, well, it's not me, other doctors, showing that when they compare it to MRIs and objective findings, about 75% of the orthopedic tests are usually wrong.
Yeah.
So they're showing stuff that doesn't really happen.
So, but you understand the distinction between why we're checking here? There are ones, straight leg rate tells us if there's a bulging disc. That could be interfering with the intervertebral foramen, but is that from a misalignment malposition of the vertebrae? Make sense?
Yeah.
So all four of these have to be present to make the definition of vertebral subluxation positive.
Yeah.
Cool. All right, so, and then static palpation, that just tells us where those bones are sitting, right? Doesn't tell us anything else. It might even show us some muscle tension, it might show us active muscle trying to pull a segment back into place. But all it indicates is there's malpositioning. Fair enough? All right. And again, these are coming out of me. This has already changed in the even last night I was going through this again. I was like, let's add that one. Let's take that one away. Let's get rid of those. So this is something I've never seen anybody else do. Now, I'm not saying it's not out there. I could have seen it someplace and just forgot. But this is something I wanted to investigate to say, am I doing what I say I'm doing? And how does it fit? Because we get stuck in these patterns of, I'm only going to do this. Well, if that only shows me part of what I say I'm looking for, I'm doing myself, the profession, and my clients a disservice. So that's why I wanted to do it. All right, so unfortunately, range of motion just doesn't show us adaptation or pattern. It just is part of it. So those are just my frowny places. I don't think I use those anywhere else.
Can I ask something?
Absolutely.
Why then rate of motion won't be a pattern if the patient always comes with the same restriction
Mhm.
in the same?
It could be part of it, but by itself doesn't show us pattern. I guess, now that you make me say that, none of these can show by itself pattern except for assessment technique. Because techniques is a group of things, so. All right, I'm done.
Yeah, but range of motion can be, according to Moby,
Mm.
that's what he's looking at, Moby versus, there's restriction because of degeneration or muscle spasm or something like that, and that may be a pattern, but it isn't a pattern based upon subluxation. That's my guess.
Oh, good, okay, I'll continue now.
Yes,
But the range of motion, it does show a system range. I'm only going to use the check mark to the furthest right. So it does give us some specificity. So could it be useful? Yes, absolutely it is. Motion palpation gives us a segment. Can it give us a listing? Partially, but maybe not. Static palpation segment at the most. Can it give us a listing? Maybe, maybe not, all by itself. But technique obviously gives us a listing. That's its purpose, right? So obviously the technique assessments, because they're built within the framework of chiropractic, are going to give us the tools we need to do it. But the technique assessment package is going to give us a lot of these things together in a toolbox. And that's why they're so useful. Staying within that package and doing that assessment protocols, not picking and choosing what you want, but doing a complete set. It's going to give you all the information to say the answer to the 3 questions. Is it there? Where is it? And what is it? All right, so is range of motion scientific? Absolutely. Absolutely. So is motion palpation, so is static palpation, and so are the techniques, right? They've all been researched and shown. But it's a question you have to ask because we say we're specific and we're scientific, right? So we have to ask it, is this scientific? Oh, here's a bunch of literature. It sure is. All right, thermography. So we have, thermography basically means picture of temperature. Got it? So we have photographic, we have full body, we have segmental, we have area, we have camera based, we have handheld based, we have 2-prong, single prong. There's all kinds of ways to do it. I've just kind of split it up into camera and a handheld. Thermography is not just chiropractic. Thermography is used in a lot of different things and a lot of different professions that have nothing to do with people care. Thermography is used in construction. Thermography is used in airplanes. Thermography used in warfare. Thermography is just pictures of heat. Here's where it got started in chiropractic. This is like 3rd or 4th generation of the nerve scope. This is the Titronic paraspinal thermography unit. This is the bar graphs that are generated if you're using a handheld device showing left and right. We'll talk a lot more about these graphs in the second hour. This is the line graphs you get out of a handheld device. There's another bar graph sample that you get out of a handheld device. And this is what you get from a camera. So we'll talk more about why this may or may not be useful in the chiropractic setting, but you can see here areas of heat, and you can see the radicular heat here, and then after whatever they did, I don't even remember where I got this from, you can see that the radicular heat's gone. So whatever it did got rid of that imbalance in heat in the low back. All right, so if we look at the thermography, does it show adaptation, balance, response of doing things? We'll understand the physiology better in the second hour, but yes, it does. It also helps us establish pattern, which all of these things can. Does it show us misalignment or malposition? No. Does it show us occlusion? No. All it shows us is there interference. And that's when you understand the paraspinal thermography. And if you look at that picture, just paraspinal, once you get past that far past the spinous processes, there's too much other things that can interfere with thermography. We'll explain that more second hour. It does show us region. It can show us a segment. It doesn't ever give us a listing. Okay, and it is very scientific in and outside the profession. So much so that both the CLA and the Titronic devices are used to validate other research. That's how strong the research is behind some of these devices. It's so settled, and I hate using settled science, but it is so robust that it's actually used as a cornerstone for other research. So that's pretty good, I think. Electrical, SCME, EMG, HRV. This is basically looking at the electromyograph, which is the electronic signals put out by the muscles in a picture format, and the S means surface. So they're basically reading the activity of the muscles and the client and comparing that side to side. And then HRV. HRV is measuring the heart rate, heartbeats, measuring the interval between the peaks. And there's several different methods. The QRS peaks, the PQRS peaks. You can measure P to P, you can measure Q to Q, you can do all these different kinds of measurements. And HRV is basically how variable is that heart rate. Little history. You guys ready for a little history?
Yes.
You don't have to take notes on this. There won't be a quiz on this part. Everything after this part has been fair game for the quiz at the end, but not this one.
Oh, I'm in the wrong class.
I know you're HRV, one of the reasons that the artificial heart failed at first, do you know the story behind that? Because it had a very precise beat, down to the millisecond. And what that did is it created standing waves of pressure in the system and actually blew out capillary beds, blew out arterioles because of that standing pressure. Is that constructive or destructive for the body? So would innate allow a standing wave to be created within the body? No, so a variable heart rate smooths out the pressure in the capillaries between the systolic and diastolic so that we don't blow them out. Makes sense, right? So HRV is a very, very good way of seeing how innate is working in the body, how balanced and adaptive we are. Make sense? And so what they had to do is they had to add electronics to the artificial hearts to set up this variable heart rate so it doesn't destroy the life that they're trying to save. Okay. Dr. Hart's a good friend of mine. He's a great guy. He's got one of the wackiest sense of humor I've ever met in my life, but he's a great guy. He's done a lot of research in HRV. And so anything by him, I would highly recommend to read and listen to and pay attention to, because it's probably going to be extremely valuable to our profession going forward. This other whack job named Christopher Kent. Anybody ever heard of this guy?
Yeah.
Gosh, what a joker. He's probably one of the smartest minds since the godfathers of chiropractic. So he is, and if he says it, you can pretty much take it to the bank, because it's probably more than just true. It's probably gospel truth. I'm blowing it up a little bit, but he's a great guy and somebody that you can really rely on to tell you what is. He also has done a lot of research into this. He also was one of the founders of CLA, and so he was part of that research team that developed the CLA's substation and the HRV. So he's part of that whole team that helped develop that. And so the abstract, there is a balance between sympathetic and parasympathetic. We covered that up front. The variable heart rate is directly related to the vagal activity. It's been said that if you give the vagus nerve enough chemical authority, it can kill you like that. And it's characterized by altering this autonomic nervous system, because I think the vagus nerve, it's been a long time, and this is pulling back from ancient memory. The vagus nerve is one of the only cranial nerves that has both sympathetic and parasympathetic. Am I right on that? Mm-hmm. So boom, there you go. Imagine being so screwed up that it sends 100% of both to the heart. Boom! Not good. All right, so this basically is spectral analysis, three-dimensional analysis of that heartbeat variability, helps us evaluate the autonomic nervous system and its dysfunction, function, balance, stuff like that. So it is useful, very useful. They also showed in their research that the adjustment does affect the HRV in a positive way, showing from before they were subluxated, did my assessment technology, afterwards proved they were clear, checked the HRV again, showed there's a massive difference between the two. And it's always been favorable. So this again proves an 8, when it is allowed to do the job, is only going to do something that's constructive and propelling for the health and vitality of the body. All right. And that's just a picture of what's going on there. I mean, it could be millions, it could be thousands of a second difference, but all of that makes a big difference. And this is just them showing how the graph is built. Won't bore you with that. So HRV shows adaptation. Either you're adapting or you're dying. It does help you establish pattern. It can, of course, everything can help you establish pattern. It doesn't show us malposition. Doesn't show us malfunction. Doesn't show us occlusion. All it shows is there's an imbalance in the autonomic nervous system someplace. So it doesn't show us interference at the vertebral IVF. Maybe. I want to put a check mark here because I love Christopher Kent. I wouldn't want him to be mad at me, so I'll just give him the credit.
But it doesn't specifically measure, because we use HRV in the practice, and from my perspective, you have to be, you're measuring off a single point, whether it's your ear or your finger versus the spine.
Right. So again, it doesn't give us that resolution to where is that interference coming, where's that imbalance come from. It could be cranial, it could be spinal, it could be extraspinal. And so again, I'm just giving credit here because we are dealing with vagal nerve, but the vagus has nothing to do with any IVF, does it? It's brainstem, so it has to do C1, C2, C3, misalignment. It's not IVF, that's, what's that thing called? Canal. Come on, guys.
Sure.
So it does show a system, but doesn't resolve anything less than that. Is it scientific? You betcha.
Question.
Yes.
What's the significance of the arrow versus the check?
We can't. We can't directly measure pressure.
Okay.
We can only assume. And this is wrong because you can't assume the interference is coming from the definition of subluxation unless you have M and O also.
Okay.
Then you can assume that, but I just put it in there because there's nothing in P because we can't measure yet.
Sure.
SEMG gives us regional. Is it scientific? Yes. Right? So SEMG is all the muscles working in the cervical spine. That might give us a segment that's out, but it's probably more bigger than just a segment. More bigger. That's grammatically correct when you're speaking. Imaging, X-ray, CT scan, video, MRI, US, ultrasound, CBCT. You guys see where we're going with this, right? Mm-hmm. I remember introducing Ian Bulow the first time I heard about CBCT, and he was going to speak on it. They asked me to introduce him. I said, leave it to chiropractors to dip their films in CBD oil to get a different picture. And he almost couldn't do his talk. But, so CBCT stands for cone beam computed tomography, obviously. So X-rays, the CT scans, which is basically computed tomography, which is again advanced X-rays, MRI, video fluoroscopy, all of these imaging things. This is really cool. This is an ultrasound of the spinal cord. Isn't that cool? Yeah. We'll just keep going here, and then CBCT, showing the different things going on. So imaging doesn't show us adaptation pattern. It shows us the state of adaptation, but it doesn't show us you're adaptive. It shows that, this is a play on words, wow. It shows us the state of adaptation, but it doesn't show us the adaptive state they're in. It shows us the accumulation of adaptation up to that point. Because bone spurs, all that stuff are adaptation, trying to solidify, make a bad thing positive. But does it show us pattern? Yes, it can play a part of the pattern just like everything else can, right? So again, I need to probably modify this. Does it show us occlusion? Yeah, M&O, this is the strong point of imaging, right? But does it show us pressure? No. Does it show us interference? No. Not really. But it can give us a listing.
But But if you have the occlusion, doesn't you have the?
If you don't have interference, you can't, if you occlusion, you can assume, but just because something's smaller doesn't mean it wasn't meant to
But
be
you're
that way.
making pressure to the nerve.
No, maybe it looks smaller, but the body's like, no, that's normal for me.
Yeah, I see.
Make sense?
Yeah.
Yeah, just because it's not the same side to side doesn't mean it's wrong. Just look at your hands, right? I got a freckle on this one and not on this one. It's just the way I was built. Okay, so you have to be careful on those assumptions, unless I say they're okay in my class. It is a scientific, absolutely. It's part of chiropractic history as well. Okay, posture. We're just going to zoom through this because I'm already over my time because we spent too long getting going. Posture analysis doesn't really show us adaptation or if they're a pattern. It can give us some clues, but by itself doesn't give us enough information. It tells us if the system's imbalanced, but it doesn't give us any resolution beyond that. And is it scientific? There's a lot of studies behind it. Got all kinds of things we can measure and assume. So putting it all together. Oops, hold on. You like that? So let me do this real quick. So are there any, oh my goodness. There it is, okay. So, is there anything that fills all the check boxes? The only thing that comes close is our technique assessments. But that is not a standalone one technique. It's a combination of things. And that's the point of this is some people rely just on x-rays. And that's great. X-rays are extremely useful, but it doesn't show us interference. Right?
Yes.
Correct.
Okay. Thermography by itself doesn't show us M&O. It only shows us interference. But some people rely only on thermography, and that's not right either, is it? You get to make the decision for yourself. Your doctors, your entrepreneurs, your business owners, you get to decide what risk you want to take in your practice. But if we say that we take care of vertebral subluxation by introducing an external concussive destructive force, we better make sure that the body's got something that can adapt that to an internal corrective force. That innate intelligence has to be ready to receive it to correct something it's trying to correct already. Does that make sense? So we need to see, is there subluxation, which is what this rubric is talking about. Where is it and what is it? To help us decide what to do. That's all I'm saying with this presentation. Hopefully it sparked a little bit of thought in you to say, oh yeah, I rely too much on this and I don't rely enough on that, or I need to add this other thing that doesn't cost anything. I mean, I got an HRV scanner on my phone, a free app. I mean, I can do HRV all day long. What am I going to add to make sure that I know that it's there or it's not? I know where it's at. I know what it is so that I can do the right thing with just enough external force that the body can adapt 100% of it and nothing is left over to cause any destruction. Does that make sense? All right, so let's take a little break and then we'll get the next one going. The next one's, I don't know, maybe a little more intense. Depends if you like math or not. Yes, ma'am.
There's nothing scientific associated with posture,
I probably just didn't put the check mark on it.
and the patterns or adaptation.
Again, as our friend said, everything's part of pattern. By itself, no. By itself, no.
Because you would have to repeatedly take
Well, posture
do their
by
posture
itself.
analysis every day, and if their posture is changing.
Well, pattern though has to do with subluxation. So they can have a sore foot and have nothing to do with subluxation. Okay? So they maybe just had a posture for something not subluxation related. That's what I'm saying.
Fascinating.
Again, this is thoughts.
I think that's really good.
First steps, let's take it to the next level and then
Helps you
refine
connect
it.
the dots.
Yeah,
of how
asking
you're
questions,
thinking.
absolutely. All right, guys, let's get back here in about four minutes.
What?
We'll zoom through the next one.
Barry is PER.
Why do?
Yeah, I'll do it.